you mentioned something that's so important is the understanding of what is the sham. And I think that's something that's very important to note, and the misunderstanding that vertebroplasty no more effective than a sugar pill, right? It goes to obviously the meaning of words, but the sham comparator in those studies was essentially medial branch block. And we've seen that does have some collateral benefit. And also most of the patients were selected on a more of a chronic time scale in regards to their fracture morphology. So there are a lot of things to be considered there. And it's important to note that there hasn't been a single study that said that kyphoplasty, vertebroplasty is worse than the active control comparator. And that's something that I think bears emphasizing, and somehow it gets equated to the vertebroplasty no better than sham, which again gets into the methodology, somehow being equivalent to vertebroplasty is worse.
Yeah, let me make a couple of quick points. The first is why, when David said, you guys all quote my paper on vertebroplasty and dementia, you never complain about the methodology there. Why are you so hard on the methodology from INVEST? Is it because you don't like it? And the answer is, well, of course we don't like the results and we're focused on that. But the reason it is important to focus on the methodology behind those trials is because they changed care. Patients who would have been referred for vertebroplasty in the U.S. were no longer being referred. Patients who might have been treated in a time frame that would have effectively halted progression of other problems might be delayed. In some countries, you could no longer do vertebroplasty after these trials. And I think we're going to talk about some of our subsequent studies that came later. If you believe, like I do, that this can be life-changing, especially in the vulnerable population that we're talking about, previously proud people that are now racked by pain and unable to do the activities that keep them vibrant, bad things begin to happen. And so I do think that the point is correct. Our community has been more aggressive about looking at the flaws in those trials. But again, the other trials didn't change treatment paradigms, didn't result in people not having access unless they could afford to pay out of pocket or in whatever way they would be able to avail themselves. Let's say you were in Australia, you'd have to leave the country, I think, to get treated. And this is not limited to Australia. I think there were similar changes that occurred in Holland and again, other places. And in the United States, I'm sure there were more insurance barriers, et cetera, to getting it done. I think it had tremendous, tremendous implications. I will say that one of the things that I think is very educational for our community, and I think all communities that came out of these trials, is the need to understand trial design and the need to understand what your control is. So Dr. Friedli, again, with friends of mine, I don't know Dr. Friedli, published a paper in the New England Journal on epidural steroids. From my point of view, that study has been misinterpreted. That study compared epidural steroid with epidural lidocaine to epidural lidocaine alone and failing to show dramatic improvement of the first over the second or vice versa, whichever way I said it. The control being epidural lidocaine by itself concluded that epidural steroids basically don't work. I would read that as a steroid added to lidocaine may not work on the basis of this trial better than epidural injection by itself. But again, the headline news comes out, procedure that's done millions of times per year didn't work. And again, similar challenges with facet joint interventions. You had said one other thing that I want to expand on if I could. Not doing worse than sham or conservative therapy is confusing. I guess pain trials always do better than conservative therapy, or typically do. But not doing worse shouldn't be thought of in the context of pain only. When you look at the complications in, for example, the VAPOR trial, which compared vertebroplasty to what I would consider a truer sham, the complications in the treatment arm were less. So it's actually not, I mean, there's this incredible focus on pain, and I think that's how things develop, but there's a lot of things that can go wrong from a people having a compression fracture that worsens over time. A second one occurs, a third one occurs because of natural history. And I do believe that people will actually do worse once you get outside of the subjective assessment of pain, which is notoriously challenging, right? I fixed this pain in a patient that has many causes of pain because they're 90 years old. And they may say back to you, I have pain. But really, the question you're asking is, what about the pain that was coming from that compression fracture? What activities can you do that you weren't able to do before? And so even a discussion of doing worse, I think, gets complicated by the fact that we have such a strong focus on pain.
Absolutely.